This module is on screening your patient for safe early mobility. When we look at performing a mobility screen, the screen tells us how much the patient can do safely and independently and which parts of the movement they need help with. Whether you are in a nursing unit, in the ER, in special diagnostics, if you're in a dental clinic, a CBOC, or in the home environment, patients need help moving every day, and we need to know how to safely move them. In this module, we're going to be talking about goal setting, the types of movement that we're going to be doing with our patients, and the different mobility levels that help guide us in our decisions around safe patient handling equipment to safely move those veterans. So you'll see to the right of the screen, we have total assistance level 1. These are patients who cannot sit up safely and independently over the side of the bed by themselves. You'll hear these words over and over again in today's module: safely and independently. A level 2 patient requires moderate assistance. This is a patient who is able to sit up over the side of the bed by themselves. They may use the bed rail, they may use the head of the bed to help them get there. But the key is they can sit up at the edge of the bed safely and independently without you as the caregiver having to touch them or assist them in any way. A level 3 patient is somebody who requires minimal assistance. They are able to sit up safely by themselves, and they're able to stretch and point their legs. They can demonstrate good strength and movement in their legs, and they're able to clear their bottom from a chair or a bed, but they cannot march and step independently by themselves. They can clear their bottom, they may be a little unsteady, they still need supervision or assistance to stand, and they need help to march and walk. A level 4 patient is independent. So this is somebody who can sit up by themselves safely and independently. They can stand up, clearing their bottoms without loss of balance. They can balance for 5 seconds without swaying and losing their balance. They can march in place, they can step forward and back, and they can do so safely without you having to touch them, without you having to be right next to them. A level 4 patient, an independent patient, is somebody that you feel confident saying, yes, you can go to the bathroom by yourself. Yes, if you need to get up and get into the chair, you can do so by yourself. So we're going to explore this a little bit more. The first decision we have to make is decide whether a movement is passive or whether it is part of regular daily mobility. A passive transfer is somewhere that we do not want the patient to move. It's a transfer where moving may cause them some harm, such as getting on and off of an MRI table or a CT scanning table if they've had a potential fracture, a potential brain bleed, a potential stroke, where we're trying to figure out what the problem is and we do not want them to move. So that would be a passive transfer. Regular daily mobility occurs in the course of activities that that patient would normally do. Getting up out of a chair, getting from their car into a wheelchair, or getting up out of their car to go someplace, getting up to the bathroom. And then we have rehabilitation, which is a structured exercise or rehabilitation program for a specific impairment the patient has. For the purposes of today, we're going to talk about passive transfers and regular daily mobility. And let's look and see a few examples where we can test our knowledge. So let's consider that you are in the radiology department. A patient comes from the ER on a stretcher. They have to get an MRI of their brain with a tentative diagnosis of a cerebral bleed. Moving this patient onto the MRI table and back is an example of what? Passive transfer or regular daily mobility? Hopefully, you have all said that this is passive transfer. Or if you're watching this by yourself for enduring material, you've already thought through, yep, this is a passive transfer, because we don't want the patient to move. What about this example? You're in a dental clinic. A patient comes in a wheelchair for their regular oral cleaning. They need assistance to get from the wheelchair into the dental cleaning chair. What is this movement an example of? Well, this is an example of regular daily mobility, because normally we would just get up out of our chairs or walk in and sit in the dental chair. So this is regular daily mobility. You're on the medical surgical unit. Your patient rings a bell to request assistance getting up to the bathroom. This movement is an example of, is it passive transfer or regular daily mobility? Hopefully you are all saying regular daily mobility, and that would be the correct answer. What about this one? This creates a little bit more confusion for people. You're on the med-surg unit. Your patient rings a bell to request assistance repositioning in bed. What kind of movement is this an example of? I'm going to give you a moment here. If you're in a classroom, discuss this amongst yourselves. If you're watching this as enduring material on your own, what do you think the answer is? You may have had some disagreement here. The answer is actually regular daily mobility. Many of you may have said passive transfer because so often we do perform this passively for a patient. But moving themselves around in bed requires a patient to use their core muscles, to push with their legs, to move their arms, maybe to roll onto their sides. It's a great way for them to move themselves and use their own muscles. So in the early mobility module, you will see various different ways to utilize safe patient handling equipment to build active patient participation into their daily care activity. And that's really the goal that we're trying to achieve with safe early mobility, is to get the patient involved actively as often as we can in whatever way they can. So you may be able to put a friction reducing device, a slide sheet under your patient, and have them boost themselves. They may be able to turn on their side and scooch themselves up. You may be able to put a repositioning sling under them and lift it a little bit, and then they can walk themselves up with their legs. So this is actually an opportunity for regular daily mobility. And I would challenge every single person watching this module to try and build mobility into repositioning, boosting, turning for every single patient that has some ability to move. So let's go to a knowledge check. Which of the following patients should be passively moved with full body support? Is it A, patients with suspected fractures? Is it B, a patient who's in a coma or fully sedated in the ICU? Is it C, a patient transferred onto the operating room table? Or is it D, all answers are correct? Hopefully all of you have answered D, that all of these are examples of passive movement. So let's assume that the patient has been screened for medical contraindications. They are ready to get up and move. We have to set a mobility goal for the patient, and we have to screen them to see how much of that goal, remember, that they can do safely and independently, and which parts of that movement they need help with. Now, we're not talking about passive transfers anymore. The rest of this module, we are going to be talking about regular daily mobility. For our passive transfers, we want to use the total body support solutions, a repositioning sling, air-assisted devices, the seated slings, where those patients have full body support. But for the regular daily mobility, we want to look at the tools in a different way to say which safe patient handling tools will allow those patients to use as much as they actively can and still be safely supported while they achieve their mobility goals. So the goals we can break into bed level goals, sitting up, transferring and standing, and then walking. When a patient is admitted, the nurse or the provider will determine if they're at their baseline, what's normal for that patient. And if they're not at their baseline, then we're working towards restoring baseline level. If they are coming into our hospital or our institution at baseline, we are looking to maintain that level for our patients. The big challenge before us is that no veteran, no patient will acquire hospital deconditioning and immobility syndrome while they are in our care. So the functions of the mobility screen are to help guide appropriate care decisions. When we think about daily care, think about how did they do things before they came to hospital? Are they at their baseline? If they're not, how can we get them there? And how can we incorporate mobility, safe mobility, into daily care and help the patient maintain as much independence in their activities of daily living as they were doing at home before they came to hospital? So there's several ways that we can build mobility in and that we can do the mobility screen and make these decisions throughout the day. Toileting. 4 to 8 times a day, a normal bladder will request to be voided, right? So we normally get that stimulus to go to the bathroom about 4 to 8 times a day. Heels for meals. If our patients are able, we're sitting them up for meals. If they can do it by themselves, they're going to sit up by themselves. If they cannot do it by themselves, unless there is a medical contraindication that requires them to stay in bed, then we should be using equipment to help them sit up at the edge of the bed or into a bedside chair for breakfast, lunch, and dinner. We don't have to walk every patient down the hallway. Sitting up at the edge of the bed or sitting in their chair may be their appropriate goal. If they were walking before they came to hospital, absolutely they should be walking in the hospital. But if their medical condition is such that sitting up is the maximum that is recommended for them medically, then we can still use equipment to help safely get them. Repositioning in bed, we've already talked to. Little movements frequently throughout the day can help strengthen those muscles. So other activities of daily living, brushing teeth, getting dressed, washing, shaving, combing hair. The more we allow a patient to do for themselves safely with the right equipment, the more independent we're going to help them be. So the mobility screen, like we said before, helps you tell what the patient can do safely and independently and where they need equipment. I want to share briefly that you do have these notes already in the VA AES initial patient assessment, their admission assessment, and your shift assessments. So for RNs, we want to see this documented every shift. There's a mobility tab. And then when you look at the mobility tab, it's going to open up to the mobility goal. And you'll see here, this is the Johns Hopkins mobility goal. And you'll see that a level 1 is lying in bed. Level 2 is turning the patient, turning themselves in bed or exercising in bed. tilting, sitting up, getting progressive upright activity in bed. A level 2 patient can be got out of bed to sit in a bedside chair with a mechanical lift. Level 3 patients are sitting at the edge of the bed. So remember the goals, bed activity is a 1 and a 2, sitting is a 3, transfer and standing is a 4 or a 5. And then goals 6, 7, and 8 are all walking goals. A 6 is a few steps. That's typically your transfer from a bed to a chair. A goal of a 7 is in the room walking, 25 feet or 25 steps, which is typically from the bed to the commode into the bathroom, but it's basically in their room. And then 250 feet is typically walking out in the hallway, and this is more of your community distances. And then we look at how many times a day, and was the mobility goal discussed with the veteran, discussed with your patient. This is so very important that we share the mobility goal with the patients. This is one of the areas where providers can really help strengthen a mobility program, is for them to be asking the patients, what's your mobility goal today? Did you achieve it yesterday? How did that go? What equipment did you use? We're reinforcing that message across all care team members that mobility and getting up out of bed is really, really important. And then if you have a stride program, some of the facilities do, some don't, but there is documentation in here for how many steps and how many minutes. Then we get into the mobility screen, and this is in your VA-AES shift assessment right now. You'll see this language. If the patient is unable to sit up independently at the side of the bed, we're on the left-hand side here, then they are total assistance level 1. The lifts that you may use are ceiling lifts, friction-reducing devices, progressive tilt technology, including the standing bed and the sitting beds. So know the technology in your beds and know what you have access to for your total assist patients to still mobilize them. If they can sit up by themselves, then you go to see if they can stretch and point their legs. And we're going to demonstrate this in just a moment. If they are unable to fully extend at least one leg, or if they're unable to clear their bottom from the chair or the bed, then they are going to remain a level 2 moderate assistance. So the way the mobility screen works is you're automatically level 1 total assistance if you cannot do anything. You have to test out of the level. So if you pass the test, you're already a moderate assistance level 2. If you fail to be able to sit up independently, you remain a level 1. If you pass level 2 and you're able to stretch and point your legs and you're able to lift your bottom off the bed for 5 seconds, then you are a level 3 minimum assistance. Even if you're a little unsteady, if you can clear your bottom and if you can stretch and point your leg, then you are in the minimal assistance range. The next question is, can you march in place? And can you step forward and back safely and independently? If you fail to do that safely and independently, you remain a level 3. Remember, you get to the level and then you test out of it. If you test out of it, you move on. If you fail, you remain at that level. And then a level 4 means you are independent and you can step forward and back safely with or without an assistive device. And we'll talk about this a little bit more in a moment or two. In your notes, you also have a spot where you can document how the patient tolerated mobility, whether or not physical or occupational therapy is involved in the patient's care, and whether the gait was steady, unsteady, shuffling, wide base, unable to ambulate. There's a spot in the notes for you to write that too. The other note title that you can document your mobility in is the frequency note, the nursing frequency note. There is an activity and mobility tab in there. And this is where you document what you actually did to achieve that mobility goal. So if the patient got up to the bathroom, you can write that they walked. If they were unsteady, you can write that they used a ceiling lift with an ambulation harness or a floor-based lift where the foot plate comes off. And that's where you show that you actually did the mobility for your patients. So remember, the purpose of doing this screen is to look at what the goal is, to see how much of it the patient can do by themselves safely and independently, and what equipment would be appropriate to support them actively participating to achieve their goal. And we're going to go through many, many cases to show you how this works. So what we do, this is a bridge document, and you will have this as a poster available to you in your facility. You have to know the patient's goal. That's across the top. So bed level, this is your Johns Hopkins HLM 1 and 2. Remember, we talked about that in the documentation. Sitting up, that's a level 3 in the Johns Hopkins HLM. Standing up, we're looking at a 4 and a 5. Walking is 6, 7, and 8. Remember, a 6 is a few steps, just we transfer into a chair. A 7 is walking in the room. An 8 is out in the hallway, 250 feet. We then look at the mobility level. Remember, a level 1, total assistance. I need help to sit at the edge of the bed and all other activities. Level 1, total assistance, does not mean that they cannot walk. It means they cannot do so safely on their own without equipment. So if you've got a patient whose goal is to stand up or to walk, but they are total assistance because they need a little bit of help sitting at the edge of the bed, this tool gives you the tools that you have available to help them achieve the goals safely. That's a really, really important point to take away from this module. The goal is medically what they should be able to do. The screen tells you how much of that they can do independently and how much of it they need physical assistance with. And rather than manually assisting them, we are using the equipment to provide that assistance.
Begin the mobility screen to see what the patient can do. Ask the patient to try and sit up. The patient can use the bed or the bed rail if they need to, but what you're looking for is that they can sit safely unsupported and they can shake your hand across the middle of their body once they get there. If the starting point is a chair, ask them to sit forwards and stay in that position without resting on the backrest or using their hands for support. If they cannot, then you know they need help even to sit. This patient is level 1 and requires total assistance. If the patient successfully passes step 1, you know they can sit up independently and you advance to the next step. The next question is, can they stand up safely by themselves or do they need help? Before we even ask them to stand, we need to know if they have good strength and movement in their hips, knees, and ankles. Trying to stand up when both legs are weak and do not have the movement needed puts the patient at risk for a fall and also puts the caregiver at risk for an injury. Ask the patient if they can stretch out their leg and point their toes. They must be able to almost fully straighten at least one leg to pass this step. If they succeed, you know they have enough strength and movement to go on to the next steps. Ask the patient to try and stand, clearing their buttocks from the bed or the chair, and holding for 5 seconds. They should be able to stand safely without swaying or faltering for the full 5 seconds.
If they fail to stand and clear their bottom, or they fail to stretch their legs, they will remain a level 2. They will require moderate assistance, and they will require a powered device to help them stand up.
If they succeed, you now know that they can sit up, can stand without swaying or faltering, with or without support, but cannot step forward and back steadily and with good balance. If they succeed, you now know that they can sit up and stand up independently. Next, you need to determine if they can walk safely by themselves or if they need help. Ask the patient to march in place and then step forward and back with one foot and then the other. They should be steady and have no loss of balance. If the patient is unable, then they will remain at level 3. They may require the help of a non-powered stand aid or device, and they will need assistance to walk. If the patient has passed all the mobility screening steps, they have demonstrated the ability to sit up, stand up, and walk independently. They have reached level 4.
A level 4 patient is somebody that you feel confident telling you can get up by yourself. If you have any doubts, refer the patient back a level. Still use equipment to promote active participation, but always, if in doubt, go back one level and use the equipment that will keep everybody safe. With the mobility screen, if a patient is independent with their walker or cane or assistive device, they can still be a level 4 independent. If they need supervision or if they need you just right there, just in case, then they will be level 3 minimum assistance. If the patient is level 4 independent and they've demonstrated good balance, but they have a high fall risk, perhaps they've fallen in the last couple of days, or they're on multiple medicines which make them at risk for falling, it is still prudent to use an ambulation harness or a fall arrest device when walking with those patients, even though they may test at a level 4 at the bedside. Remember, the whole purpose of this mobility screen is to actively help patients achieve their daily mobility goals, but to do so safely. So if you think your patient is at risk for falls, do not leave them in bed. Get them up, walk them, but put a harness on them or put some kind of device that if they fall, they are safe. So let's practice with the mobility levels. Your patient can sit up by themselves with the help of the bed rail. Once sitting, he can balance and reach across his body to shake your hand without losing balance. He is unable to stretch either leg and bend his ankle. What is your patient's mobility level? Again, discuss it amongst yourselves or have a think about it if you're on your own. He can sit up and shake your hand without losing balance, but he is unable to stretch and point either leg. Hopefully you answered moderate assistance. This patient can sit independently. They just don't have enough strength in their legs to try and stand up. What about this one? Your patient can sit up by themselves with the help of the bed rail. Once sitting, he can balance, he can reach across his body, he can shake your hand, he can stretch and point both legs, he can clear his buttocks from the bed, but he's unsteady when he stands up. He cannot stand and hold it for 5 seconds, but he can clear his bottom. What is your patient's mobility level? Is it total assistance? Is it moderate assistance? Is it minimum, or is it independent? Hopefully you answered minimum assistance. He can clear his bottom. That's the key factor here. If he was unable to clear his bottom, he would have remained a level 2 moderate assistance. But because he can clear his bottom, he may be unsteady. That's why he's not a 4. But because he can clear that butt off the bed, he has a level 3 minimum assistance. Is it safe for this patient to stand up by himself when you are not there? Hopefully all of you said no, because he's unsteady. For him to stand up by himself, he's putting himself at risk of a fall. Is it safe for him to sit up by himself when you are not there? Hopefully you answered yes. He's demonstrated that he can sit up safely and independently. Now this patient, if you're going to come in at 8 o'clock in the morning and do vital signs, you can tell him, hey Jim, I want you sitting at the edge of the bed at 5 to 8. I'm going to be here at 8 o'clock to do vital signs with you. I want you to sit up and be ready for me. That's a mobility event throughout the patient's day. Let's look at another one. The same patient has been up in a chair for several hours. Remember, he was minimal assist this morning. He wants to go back to bed. He can sit forward by himself. He can clear his back away from the chair. He can reach across his body to shake your hand without losing balance. He can stretch and point both legs. But when you ask him to stand, he cannot clear his bottom. What is his mobility level now? Hopefully you all said 2, moderate assistance, because he cannot clear his bottom up. He's got enough strength in his legs for us to try and stand, but he needs power to stand up out of that chair to get back to bed. Is it safe for you to manually lift him, transfer him back to bed? Hopefully everybody right away said no to that answer. He needs power to help get his bottom up to stand. Now, he may be able to participate just because he's in a powered device. You can still have him try to help in the device, but he should be actively participating. He does need power. Your patient wants to go to the bathroom. The goal today is walking. They can sit up without help. They can stretch and point their legs. They can stand up without assistance. They can step forward and back without loss of balance. What is their mobility level? Hopefully you all said 4, independent. Right now, he does not need any equipment. So we want to know the daily mobility goal, know the precautions, perform the mobility screen to see what the patient can do safely and independently by themselves, and then choose the appropriate equipment to help them achieve their daily mobility goal. The algorithm that we have here, the bridge document, is going to help you do that. We're going to go through a few more examples. So Johnny is 77 years old. He weighs 315 pounds. He had a severe CVA 2 days ago and is in a ventilator in the ICU. The medical team agree that Johnny's goal is sitting up until therapy comes to evaluate him. He's unable to sit up and cannot roll to either side without a lot of help. The RN has asked you as unit peer leader to help identify the appropriate safe patient handling equipment to help Johnny sit up. What is Johnny's mobility level? Remember, he cannot roll, he cannot sit up by himself. A is the correct answer. Johnny is total assistance, requires assistance with all activities, is level 1. Which solution of those that you see here is most appropriate to help Johnny sit up today? Is it a powered stand aid? Is it an ambulation harness with a floor-based lift? Is it the sitting up function of the bed? Or is it air assist technology? The correct answer is C, because Johnny's goal is sitting. We don't have to test, can he stretch his leg, can he stand, can he step and march, because the medical team has set his goal at sitting up. So any of the standing devices are not appropriate, and we do not need to do those steps of the mobility screen. We just need to see how much help does Johnny need to sit up, or can he do it by himself? So let's look at Jenny. Jenny's a 75-year-old female. She weighs 172 pounds. She's on the med-surg unit. She has anemia. as she has lost a lot of blood due to a GI bleed. The medical team agree that Jenny's goal is sitting up today. Jenny has the same goal as Johnny for a different reason, but her goal is sitting up. The medical team do not want her standing and walking because she's lost so much blood because she's so anemic. So it's because of a medical problem. Jenny, when you ask her, can sit up by herself. She uses the bed rail, and once she's up, she can sit and she can shake your hand without loss of balance. There's a new CNA on the unit, and she has asked you as the unit peer leader to help her decide if Jenny needs any equipment. What is Jenny's mobility level? Is it level 1, total assistance? Remember, Johnny was total. He needed help to sit up. But Jenny doesn't, does she? She is moderate assistance level 2. We do not go on to stretch and point or stand because her medical condition has said no more than sitting today. So she's level 2. Which solution is most appropriate to help Jenny sit up today? Does she need a powered stand aid? No, because she's not standing. Does she need a bed chair position? No, because she didn't need any help to sit up, right? So B would be the correct answer. Jenny does not need any equipment to help her sit up, but she is not supposed to stand or walk. Now, if Jenny is to sit in the bedside chair, she may use a seated sling, but that wasn't one of your options in here, right? So in order to sit at the edge of the bed, she does not need any equipment. So when we look at the algorithm, we need to know, first of all, what is Jenny's mobility goal? Now, if we had not known that goal first, we may have gone through the whole screen and stood and walked Jenny, and we may have missed the fact that she was not supposed to do anything more than sitting today. If her goal had been standing or walking, we would have completed that mobility screen, right? The next step is complete the mobility screen. She was a level 2, no equipment needed on the bed, but may need a powered lift to get into a bedside chair if she's getting up for meals. Let's look at another one. Jeremy is a 63-year-old veteran. He had a below-the-knee amputation due to a peripheral vascular disease. Jeremy's mobility goal is to stand up on his unaffected limb to transfer to the commode or to the bedside chair. Jeremy can sit up in bed without difficulty. He can balance in sitting. He can cross midline. He can shake your hand. He can stretch and point his residual limb. But on the amputated side, he has very little stump below the knee and no prosthesis. Jeremy is unable to clear his buttocks from the bed to try and stand up. What is his mobility level? So remember, the difference between moderate and minimal is whether they can stretch and point and clear their bottom to stand. Jeremy could not clear his bottom, so he is a moderate assistance level, level 2. Jeremy is going to require what kind of device to help him safely stand up today? Remember, a moderate assistance or a total assistance does not mean they cannot get up. Jeremy's goal was to stand and transfer, weight bearing through that unaffected limb, right? So which device would be most appropriate? Is it a powered sit to stand? Is it B, no equipment? Is it C, a seated sling? Or D, a walker? Hopefully you all answered A. Obviously, Jeremy's not safe to get up by himself. He's not able to use a walker because he can't clear his bottom to stand up. And a seated sling is not going to help him achieve his mobility goal. So when we look at the algorithm, Johnny's goal was to stand. When we looked at the mobility screen, he's a level 2. When we look at the appropriate mobility device for him, oh, this went to the wrong spot. Jeremy is a level 2. The appropriate equipment are a tilt option to weight bear, a ceiling lift with a sling, a ceiling lift with a sling with guiding if necessary, but no lifting, a powered stand aid, a floor-based lift, or a ceiling lift with a walker where he has support, but he needs some kind of power to stand him up. So Jeremy is a level 2 moderate assistance. Ignore this arrow here. It should have stopped at the moderate assistance level. Joanna is 75 years old. She's a veteran who's been recovering from COVID-19. Joanna's mobility goal is standing up and transferring. She's to go to her chest x-ray, and you are about to help her get from her chair into the wheelchair. Joanna can sit up in the chair. She can cross her midline. She can stretch and point both legs. She can clear her buttocks from the bed and can stand steadily without swaying or faltering. Joanna can step forward and back without losing her balance. What's her mobility level? Total, moderate, minimal, or independent? The answer is D, independent. She could pass all steps without difficulty. Which solution is most appropriate to help her get into the wheelchair today? Is it a powered device? Is it a seated sling? No equipment, or a walker? The answer is no equipment necessary. She's independent. So hopefully you're beginning to see here how we use these tools and the mobility screen. Her goal was transferring, her level was independent, no equipment necessary. Couple more. Josie is a 54-year-old patient who had a cholecystectomy yesterday for obstructive bowel and has not had a great night. Her mobility goal is walking. She can sit up. Once she's up, she can balance. She can hold it without losing her balance. She can stretch and point both legs. When asked to stand up, she can clear her bottom, but she's a little bit unsteady. She needs to steady herself on the bed rail. When you give her a walker, she's much steadier, but you don't feel confident for her to walk on her own. What is her mobility level? Josie is a level 3 minimal assistance because you still feel you need to be right there. She was steadier with her walker, but you did not feel confident that she could step out and walk without losing her balance. So she remains a level 3. Remember, independent means you would tell them you can get up by yourself. Which solution is most appropriate to achieve Josie's goal today? Powered stand aid, no equipment, chair mode of bed, or a walker? A walker is the appropriate equipment. She was pretty steady with it, but you just didn't feel quite ready for her to go on her own. So she remains a level 3 minimal assistance, but she can use a walker. Using the algorithm, her goal was walking. She was a level 3. These are the devices that you could use. You could have put Josie in an ambulation harness. That was not one of your choices on the last slide. You could have used an ambulation device with a removable foot plate for her to walk. Those would have been appropriate options as well. Patricia needs to go for a chest x-ray, and the new x-ray tech has asked you to help them decide on the right way to get her into the wheelchair. Watch the video and decide what Patricia's mobility level is. So in your groups, did she pass step 1? That puts her in moderate assistance territory, right? Next step, maybe you're already anticipating it. Can she stand? Does she even have enough strength and movement in her legs to try and stand? If she fails this, we don't even try because we already know that there are issues with strength and range of motion. So let's try and stand up. Can she clear her bottom? She was able to clear her bottom, wasn't she? But then what did you see? Did she pass the standing test? She didn't, did she? She was unsteady. She cleared her bottom, but she was not steady to move on to the next level. So what is her mobility level? Talk about that just for a second in your group. Is she total, moderate, minimal, or independent? Obviously, you can rule out total because she was able to sit up by herself. You can rule out independent. Was she moderate or minimal? The answer is C. She was able to clear her bottom, so she was minimal assistance. Which solution is most appropriate to help get Patricia in the wheelchair today? Non-powered stand aid, no assistive equipment, a powered stand aid, or a ceiling lift with a seated sling? The answer is a non-powered stand aid. You walk by a patient room in the CLC and you notice the patient is trying to get out of bed. You see this sign below on their door. What is the appropriate action to take, no matter who you are, whether you're a provider, a nurse, a therapist, a housekeeper, a case manager, an administrator? What's the appropriate activity? Do you keep walking as you're very busy and this is not your patient? Do you let the nurse know their patient's trying to get out of bed? Do you go into the patient room and tell the patient they should not try to get up on their own and call the nurse while you wait with them? Or do you go in and help the patient get up to the bathroom because they obviously need to go? The correct answer, I think you would all agree, is C. You go into the patient room. You know just by that level 1. Now, if it said a 2 or a 3, your action would be the same. It would only be if it was a level 4, independent, and you saw the patient trying to get up on their own. If you saw a level 4, you wouldn't necessarily worry. But if they're 1, 2, or 3, you know that patient is at risk for falling if they're getting up by themselves. Your patient is ready to go home after their clinic appointment. They were able to stand up from their wheelchair and walk to the procedure room chair. You do a quick screen as they're going to get up. Watch the video and rate their mobility level. Shake my hand. Good. What about this one? All right, you know the drill. Stretch out. You like to do both legs at the same time. All right. Can you stand for me? Can you stand up? Can you get both feet underneath you? All right. No. Okay. All right. So this patient, what is their mobility level? They are moderate assistance. The solution to get them up, hopefully you're getting faster at this point, is going to be C, a powered stand aid. So review, know the movement. Is it passive? Is it part of their daily mobility? Know what kind of movement you're looking at. Know your patient's mobility goal from either the RN or from the medical team. Screen the mobility to determine how much that movement they can do by themselves and how much they need help with. Select the appropriate safe patient handling solutions to safely achieve the mobility goal for both the caregiver and the patient. Always screen your patients, but getting them up, no matter how many times it's been done that day. That last video you just saw, that patient was able to get up from a higher surface, but that chair was lower than what they could get up from. That's going to result in a lift manually if you assume that they can still get up by themselves. Always do the screen. It takes about 20 seconds to do. Let your RN know if there's a change in mobility goal. Let the provider know if there's a change in mobility level. Let the providers know if that change in mobility level persists over more than 2 shifts. So you've successfully completed the module on patient mobility screening and assessment. We hope that it's helped you solidify your knowledge and feel confident screening your patients and appropriately selecting the right equipment to actively help your patient participate, to meet their mobility goal and keep everybody safe. Thank you for your service and giving back to those who have served us.